Hi! Welcome to the part 2 of chapter 5 of Principles of Surgery by Schwartz. And the title is Shock. Let's proceed on the pathophysiology of shock. Regardless of etiology, the initial physiologic responses in shock are driven by tissue hypoperfusion and developing cellular energy deficit. This imbalance between cellular supply and demand leads to neuroendocrine and inflammatory responses, the magnitude of which is usually proportional to the degree and duration of shock. The specific responses will differ based on the etiology of shock, as certain physiologic responses may be limited by the inciting pathology. For example, the cardiovascular response driven by the sympathetic nervous system is markedly blunted in neurogenic or septic shock. Additionally, decreased perfusion may occur as a consequence of cellular activation and dysfunction, such as in septic shock and to a lesser extent, traumatic shock. Many of the organ-specific responses are aimed at maintaining perfusion in the cerebral and coronary circulation. These are regulated at multiple levels, including A. Stretch receptors and baroreceptors in the heart and vasculature. That is your carotid sinus and your aortic arch. Letter B. Chemoreceptors. C. Cerebral ischemia responses. D. Release of endogenous vasoconstrictors. E. Shifting of fluid into the intravascular space. And F. Renal absorption and conservation of salt and water. Furthermore, the pathophysiologic response vary with the time and in response to resuscitation. In hemorrhagic shock, the body can compensate for the initial loss of blood volume primarily through the neuroendocrine response to maintain hemodynamics. This represents the compensated phase of shock. With continued hypoperfusion, which may be unrecognized and cellular death and injury are ongoing, the decompensation phase of shock ensues. The decompensation phase. Microcirculatory dysfunction, parenchymal tissue damage, and inflammatory cell activation can perpetuate hypoperfusion. Ischemia and reperfusion injury will often exacerbate the initial insult. These effects at the cellular level, if untreated, will lead to compromise of function at the organ system level, thus leading to the vicious cycle of shock. Persistent hypoperfusion results in the further hemodynamic derangement and cardiovascular collapse. This has been termed the irreversible phase of shock and can develop quite insidiously and may only be obvious in retrospect. At this point, there has occurred extensive enough parenchymal and microvascular injury such that volume resuscitation fails to reverse the process, leading to death of the patient. In experimental animal models of hemorrhagic shock, modified Weger's model, this is represented by the uptake phase or compensation endpoint, when shed blood must be returned to the animal to sustain the hypotension at the set level to prevent further hypotension and death. If shed blood volume is slowly returned to maintain the set level of hypotension, eventually the injury progresses to irreversible shock, where further volume will not reverse the process and the animal dies. Next, neuroendocrine and organ-specific responses to hemorrhage. The goal of the neuroendocrine response to hemorrhage is to maintain perfusion to the heart and the brain, even at the expense of other organ systems. Peripheral vasoconstriction occurs and fluid excretion is inhibited. The mechanisms include autonomic control of peripheral vascular tone and cardiac contractility, hormonal response to stress and volume depletion, and local microcirculation mechanisms that are organ-specific and regulate regional blood flow. The initial stimulus is loss of circulating blood volume in hemorrhagic shock. Again, the initial stimulus is the loss of circulating blood volume and hemorrhagic shock. The magnitude of the neuroendocrine response is based on both the blood volume lost and the rate at which it is lost. Afferent signals. Afferent impulses transmitted from periphery are processed within the central nervous system and activate the reflexive effector response or efferent impulses. These effector responses are designed to expand plasma volume and maintain peripheral perfusion and tissue oxygen delivery and restore homeostasis. The afferent impulses that initiate the body's extrinsic adaptive responses and converge in the CNS originate from the variety of sources. The initial inciting event usually is loss of circulating blood volume. Other stimuli that can produce the neuroendocrine response include pain, hypoxemia, hypercarbia, acidosis, infection, change in temperature, emotional arousal, and hypoglycemia. The sensation of pain from injured tissue is transmitted via spinothalamic tracts, resulting in activation of the hypothalamic pituitary adrenal axis, as well as activation of the autonomic nervous system to induce direct sympathetic autonomic nervous system stimulation of the adrenal medulla to release catecholamines. Baroreceptors also are an important afferent pathway in the initiation of adaptive responses to shock. Volume receptors sensitive to changes in both chamber pressure and wall stretch are present within the atria of the heart. They become activated with low volume hemorrhage or mild reductions in right atrial pressure. Receptors in the aortic arch and carotid bodies respond to alteration in pressure or stretch of the arterial wall. Respond to alteration in the pressure or stretch of the arterial wall. However, the baroreceptor responds to pressure, responding to larger reduction in intravascular volume or pressure. These receptors normally inhibit induction of the ANS. When activated, these baroreceptors diminish their output, thus inhibiting the effect of the ANS. The ANS then increases its output, principally via sympathetic activation at the vasomotor centers of the brainstem, producing centrally mediated constriction of peripheral vessels. Chemoreceptors in the aorta and carotid bodies are sensitive to changes in oxygen tension, hydrogen ion, and carbon dioxide levels. Stimulation of the chemoreceptors results in vasodilation of the coronary arteries, slowing heart rate and vasoconstriction of the splanchnic and skeletal circulation. In addition, a variety of protein and non-protein mediators are produced at the site of injury as part of the inflammatory response, and they act as afferent impulses to induce a host response. These mediators include histamines, cytokines, eicosanoids, and endothelins, among others that are discussed in greater detail later in this chapter, in the immune and inflammatory responses section. That's it for afferent signals. Let's go to efferent signals. Cardiovascular response. Changes in the cardiovascular function are a result of the neuroendocrine response and ANS response to shock, and they constitute a prominent feature of both body's adaptive response mechanism and the clinical signs and symptoms of the patient in shock. Hemorrhage results in diminished venous return to the heart and decreased cardiac output. This is compensated by increased cardiac heart rate and contractility, as well as venous arterial vasoconstriction. Stimulation of sympathetic fibers innervating the heart leads to activation of beta-1 adrenergic receptors that increases heart rate and contractility. Again, it increases the heart rate and contractility if the beta-1 adrenergic receptors is activated. This is done in attempt to increase cardiac output. Increased myocardial oxygen consumption occurs as a result of the increased workload. Thus, myocardial oxygen supply must be maintained, or myocardial dysfunction will develop. The cardiovascular response in hemorrhage, hypovolemia differs from the responses elicited in the other etiologies of shock. These are compared in Table 5-2, and you should check on that. Direct sympathetic stimulation of the peripheral circulation via activation of alpha-1 adrenergic receptors on arterioles induces vasoconstriction and causes a compensatory increase in the systemic vascular resistance and blood pressure. The arterial vasoconstriction is not uniform. Marked redistribution of blood flow results. Selective perfusion to tissues occurs due to regional variation in arteriolar resistance, with blood shunted away from the less essential organ beds such as intestines, kidney, and skin. In contrast to the brain and heart, have autoregulatory mechanisms that attempt to preserve their blood flow despite a global decrease in cardiac output. Direct sympathetic stimulation also induces constriction of venous vessels, decreasing the capacitance of the circulatory system and accelerating blood return to the central circulation. Increased sympathetic output induces catecholamine release from the adrenal medulla, and catecholamine levels peak within 24 to 48 hours of injury and then return to baseline. Persistent elevation of catecholamine levels beyond this time suggests ongoing noxious afferent stimuli. The majority of the circulating epinephrine is produced by the adrenal medulla, while norepinephrine is derived from the synapses and the sympathetic nervous system. Catecholamine effects on peripheral tissues include stimulation of hepatic glycogenolysis, gluconeogenesis to increase circulating glucose availability to peripheral tissues. So that's it for part 2. We will proceed to part 3 later, and we will read on efferent signals from hormonal response.